Welcome to the Neuroblastoma Parent Global Symposium. I'm Antonia Palmer from Neuroblastoma Canada, and I will be moderating the session. This session is low and intermediate risk neuroblastoma, which is being delivered by Dr. Holly Meany, who is a pediatric oncologist at Children's National Hospital in Washington, D.C. Before I hand over, I'd like to draw your attention to the Q&A button at the bottom of the screen to submit questions during the session for the speaker to address at the end of their presentation. If the button is not showing up, just tap or hover your cursor over the screen to bring it up. If you see a question that you like, give it a thumbs up to move it up the list. Dr. Meany, thank you so much for joining us today. The floor is now yours.
Thank you so much for the kind invitation to present on the topic of low and intermediate risk neuroblastoma, often termed non-high risk neuroblastoma. And it's truly a pleasure to be here, though virtual, with you all today. And overall, the story of non-high risk neuroblastoma is a successful one, and I hope to describe how this success came about, what challenges have been identified, and the questions that remain to be answered. Sorry about that. So I'll begin by providing a brief background on neuroblastoma, including how patients are classified, and in general terms, treatment modalities. And this information may be well known to members of the audience, but I do hope will set the stage for our discussion today. By reviewing prior non-high risk neuroblastoma clinical trials, I hope to demonstrate the thoughtful, stepwise progress that has been made and lessons learned that have informed the next generation of clinical trials. And I will highlight current non-high risk neuroblastoma clinical trials, focusing on two large clinical trials being conducted in the Children's Oncology Group and the International Society of Pediatric Oncology, the European Neuroblastoma Group, or CIOPN. And finally, I will discuss future directions. So neuroblastoma accounts for approximately 8 to 10% of childhood cancers, and it really is a disease of young children. It is the most common tumor detected in infants less than 1 year of age, and approximately 90% of patients are diagnosed before 5 years of age. And there's an interesting spectrum in neuroblastoma, both of disease presentation and in outcome. Disease can be localized or widely metastatic. Some patients demonstrate spontaneous regression or resolution of their disease without any intervention. And on the other end of the spectrum, we have patients with aggressive disease who experience only modest cure rates despite our most intensive multimodality therapy. And prognostic variables for patients with neuroblastoma have been identified and are used to classify our groups of patients. The key factors include the patient's age at diagnosis, and although not universal, typically less than 18 months of age is felt to be more favorable. Disease stage is very important, and the table on this slide describes the current staging system, the International Neuroblastoma Risk Group, or INRG staging system. And as you can see, patients are determined to have localized disease or metastatic disease, where tumors have spread to multiple locations. And within the group of localized disease, patients are divided into those whose tumors are involving vital structures, or not involving vital structures, or L1 tumors, and those that are involving vital structures or have an image-defined risk factor, those are L2 tumors. And within our metastatic patients, there's a special group of very young patients with a specific metastatic pattern to the liver, skin, and bone marrow, and these are considered MS patients. Tumors are categorized as favorable or unfavorable based on histology, and these are characteristic features that are seen by our pathologists under the microscope review. And then finally, genomic features, which are abnormalities in the cancer cell DNA or chromosomes. These are very important in classifying patients. And again, gene amplification, I suspect well known again to the group, is a duplication of a gene on chromosome 2. And when there are too many copies present, this is highly correlated with high risk advanced disease and a poor prognosis. And due to these poor outcomes, patients are typically treated on high risk therapy protocols. The tumor cell ploidy or DNA content or amount of DNA is also important. And hyperdiploid or an increase in the amount of DNA is felt to be better, more favorable. And then finally, segmental chromosome aberrations or structural chromosome rearrangements. And several of these rearrangements are commonly seen in patients with neuroblastoma and also have been shown to be important in determining the best therapy and risk classification. So taking these variables into account, we can classify our patients as low, intermediate, or high risk disease. And this really reflects the risk of disease recurrence. And we use this to determine the best therapy. So this table that I've presented here is really just a snapshot of the risk classification schema. And as you can see, by looking at stage, age, McN status, DNA content, histology, and the presence or absence of segmental chromosome aberrations, patients can be assigned to an appropriate treatment strategy, low, intermediate risk, or high. And I just wanted to highlight that actually half of the patients who newly diagnosed with neuroblastoma are considered non-high risk. So this is a large group of patients. And the non-high risk group is actually a very heterogeneous group. And I thought it might be helpful, as patients in our non-high risk group can look very different, to look at a few patient examples. So with permission of a couple of my families, I wanted to present some examples. And here is a patient who had a mass detected actually initially on a routine prenatal ultrasound. After birth at 5 days of age, we obtained imaging that confirmed a 4.9 by 3.4 by 4.3 centimeter mass, so a very large tumor in the abdomen. Additional workup confirmed this was localized disease. So this would be a patient classified as low risk or an L1 tumor. Conversely, here is an 8-month-old patient who presented with a black eye and notable swelling of the eye, and actually was thought to be related to an injury that occurred a day before. CT imaging unfortunately revealed a large mass in the orbital bone, and further imaging revealed a large primary tumor in the abdomen that is demonstrated on this scan here. The patient also was found to have widely metastatic disease to the bones, which is demonstrated on this MIBG scan here. We can see abnormal uptake in the skull bones. This is the vertebral backbone here within the legs, and uptake in the liver. So widely metastatic disease with lots of bulky tumors as well. And this patient was classified as MS. So as you can see, these patients look very different, but are still lumped together in the non-high risk category. When we think of treatment for neuroblastoma, we do base it on our disease classification. Low risk neuroblastoma patients are often observed or treated with surgical resection of the tumor. Our intermediate risk patients are generally treated with moderate dose chemotherapy over 2 to 6 months, and in select cases, surgical resection. And our high-risk patients, on the other hand, are treated with multimodality therapy. They receive dose-intensive induction chemotherapy, surgical resection, high-dose chemotherapy, autologous stem cell transplant, external beam radiation, followed by immunotherapy and a differentiating agent. And this treatment really is very intensive, extending over 18 months of time. So extremely different therapies for patients who are all considered to have neuroblastoma. And going forward, I'll discuss in more detail how some of these standard approaches have been developed for the non-high risk group. Fortunately, patients with non-high risk neuroblastoma have actually been shown to have very excellent outcomes with current therapy. In fact, it's been questioned as to whether exposure to intensive chemotherapy and aggressive surgical resection is necessary for all patients in this non-high risk group. And over time, the objective in treatment in the non-high risk population has been a reduction of therapy intensity. This allows physicians to minimize both short and long-term adverse events, but keeping in mind we need to maintain excellent outcomes. And this de-escalation of therapy has been safely achieved through large consortium group clinical trials, and I'll discuss a few examples. Conversely, there do remain patients who eventually die of their disease, either due to progression or relapse, and in whom early initiation of treatment or modification, perhaps intensification of current therapy, may improve outcomes. So treatment really does not come without risk, and I think it's something we want to consider and think carefully about. And these are not all-inclusive lists of the possible side effects seen with therapy, but it does include some of the common complications seen with both surgical resection of a primary tumor, and there is risk even to biopsying tumors, and then risk certainly with our chemotherapy, both short-term and long-term. If these can be avoided without compromising a successful outcome, it is certainly ideal for our young patients in particular. Striking the balance of curing the primary cancer, but allowing patients to live long lives complication-free is what we really are trying to achieve. So I wanted to highlight a few key studies that have led to the standard approach for patients with localized low-risk disease. And I have here 3 large clinical trials conducted several decades ago in the Children's Cancer Group, the European Psyopen Group, and the Children's Oncology Group. And these trials have really demonstrated that patients with localized disease who do not have symptoms were very successfully managed with surgery alone. These patients did not require other therapy, did not require chemotherapy or other intervention, and had excellent overall survival rates, greater than 90% in all cases, as you can see here. And a more recent Children's Oncology Group trial took the next step and actually proposed observation only for a group of patients with localized primary L1 tumors. So these were patients less than 6 months of age with a small abdominal primary tumor. They were presumed to have neuroblastoma and followed closely with imaging. A tissue biopsy was not obtained, and the reason for this strategy was really to avoid any and all risk of a procedure, biopsy or resection. And it was recommended that if there was significant tumor growth, the patient would undergo surgical resection at that time. And outcomes were excellent in this patient group, so 100% overall survival. And importantly, 81% of patients did not demonstrate tumor growth, so they were spared any surgery. And here I wanted to present some representative trials of patients in the intermediate risk category. So certainly not an exhaustive list of the clinical research that's contributed to our standard treatment approach for this cohort, but I wanted to focus on patients with localized disease that were deemed unresectable and present a few of the important trials in this group. So several of the studies that I presented here did stratify patients based on tumor biology, and therapy was assigned based on favorable versus unfavorable features. And if we look sequentially at the therapy administered to this fairly similar group, we can see that just started with 10 cycles of therapy and had a reduction with the next protocol down to 4 to 8 cycles, and a further decrease to low-dose chemotherapy with surgical resection, and finally removal of radiation therapy on the Psyopen trial. And in these patients, overall survival remained greater than 90% in all cases and approached 100% for those patients with favorable disease. And importantly, this was despite less therapy than had previously been administered. The final study conducted by the German group, the German Society of Pediatric Oncology and Hematology, evaluated observation only as the initial approach for patients with localized disease. And this did include patients who had more extensive disease, so likely those with image-defined risk factors. And spontaneous regression was seen in 47% of patients, and 12% had stable disease. So nearly 60% of the patients were spared any intervention on this trial. And all this data really supports further reduction of therapy, chemotherapy, and surgical resection, and using a refined biology-based risk stratification schema. So that gets us to a successor trial in the Children's Oncology Group, AMBL0531. And the goal of this trial was to build upon the classification of patients based on tumor biology and the reduction of therapy used on the prior studies I just presented, and really all the while maintaining the excellent outcomes that we're seeing. And on this study, the assigned treatment therapies for groups of patients was actually a reduction of therapy for those with favorable biology. So patients could receive as few as 2 cycles of chemotherapy in certain cohorts. And in addition, the duration of therapy was determined by the overall response, such that a partial response to therapy or a reduction by 50% or more than half of the tumor volume was an acceptable stopping point for patients with localized disease. And this often resulted in further reduction of therapy. The trial also included a new biologic prognostic marker, the allelic status of chromosome 1p and 11q. This is often referred to as a loss of heterozygosity, or LOH, of 1p and 11q, and it was used to stratify patients on this trial. And again, we saw very favorable results. So for the entire intermediate risk group studied, those with localized disease, and this also included metastatic patients, the event-free survival was 83.2%, and overall survival approached 95%. And importantly, for patients with localized disease, the survival was 100%. There were groups, however, that did not fare as well, and in particular, the infants with stage M or metastatic disease and unfavorable biology did fare more poorly with only a 66.8% event-free survival. And looking at this metastatic group a little bit more closely, we can see how important tumor biology is. So the outcome for those patients with favorable biology but having metastatic disease was quite superior to those who had metastatic disease with unfavorable features, particularly with respect to event-free survival. I wanted to touch briefly on the therapy for relapse disease. So ANBL0531 also looked at a standard salvage regimen for patients with relapsed or refractory non-high risk disease. Generally, the treatment in this patient group depends greatly on the initial therapy and the site of recurrence, whether localized or metastatic. For those patients who were initially observed or received minimal upfront therapy, it may be appropriate to consider surgical resection at the time of recurrence or begin or resume standard intermediate risk therapy. So thinking of those patients who received only 2 or 4 cycles, if there was a relapse or the tumor was felt to be refractory, continuing on with additional therapy may be appropriate. For others, treatment may include second-line chemotherapy regimens, surgery, radiation, even combination therapy, considering chemoimmunotherapy or early phase clinical trials if patients had multiply relapsed disease, particularly metastatic disease. And as I mentioned, a secondary aim on ANBL 0531 was to incorporate a standard salvage chemotherapy regimen to better describe the outcomes in this group. So what were the questions after 0531 to be considered for the next generation of studies? And to be honest, they were often similar to what had been considered before. Can the reduction of therapy envelope be pushed further for patients with highly favorable tumors? Can therapy be augmented for those with an inferior outcome? And what is the ideal way to classify patients? Are there new prognostic markers that need to be considered and included in our risk stratification? So this is the current COG non-high risk trial, ANBL 1232. And the trial is looking at 3 patient groups, and I'll walk you through the study schema in table form and then more in a outline form in the next slide. But the first group that is being looked at on this in this study are those with L1 tumors, so localized disease without an image-defined risk factor, without involvement of vital organs. Patients are less than 12 months of age, which is an older population that has been previously studied, and a primary tumor less than 5 centimeters in greatest diameter, so a larger tumor size than that has been previously studied. Patients may have an abdominal adrenal mass or have a primary tumor elsewhere, again, which is a change from prior studies. These tumors are not biopsied or resected. Patients are simply observed over a 2-year period. The second group that is being looked at on this trial are patients with who are at less than 18 months of age, asymptomatic, with an L2 primary tumor, so localized disease, but with an image-defined risk factor. Tumors that are involving vital organs in close proximity, wrapping around blood vessels, nerves, other organs, etc. Patients undergo tissue biopsy, and only those with all favorable biologic features continue with observation alone on study. Those with unfavorable features do come off study and are treated as per standard approach. For those that remain on the trial, if there's an increase in tumor volume, chemotherapy is initiated. And then the final group that's looked at on this study are the MS patients, so that special category of metastatic disease that I mentioned. And really all patients with MS disease are being looked at on this trial. We hope to gain a lot of information about this cohort. So in this group, the young infants less than 3 months of age who have liver involvement, which we worry could pose a significant risk to these very tiny babies. Any patient with symptoms begin chemotherapy immediately. If patients are asymptomatic, they're followed utilizing a clinical scoring system to assess the patient's clinical status, how they're doing, and that helps us to determine if and when to initiate therapy. And it's worth noting that there are several non-high risk patient cohorts that are not being studied on this trial, and the focus was optimizing therapy for the more favorable groups. And this is the study schema, again, more in an outline form. And we have the 2 groups on the left, groups A and group B, that are undergoing observation as the initial approach. And only if there is significant tumor growth would an intervention be introduced, either surgical resection or chemotherapy. And for group C, the MS babies, those that are asymptomatic with favorable genomic features are observed. and only if symptoms develop is therapy initiated. Whereas for those higher risk patients, the young babies with unfavorable features, those with a large liver or symptoms begin therapy immediately. And the SIOPEN study has many similarities to the most recent COG studies that I've discussed, and I've highlighted the similar groups here in blue. And again, reduction of therapy is a theme here as well for these very favorable groups. So a lot of similarities between trials that are being conducted in different parts of the world. And this trial, unlike the Children's Oncology group, is also evaluating therapy modifications for those with higher risk, the high risk populations. So older patients with localized disease and unfavorable biology, or patients with localized disease, but again, gene amplification, and then patients with metastatic disease. So actually a more inclusive study. So with all of that information, I wanted to return to the two patients that I presented early on. So taking into account the treatment discussion that we've had, we can see some of the principles in action. So just as a refresher, this was our newborn baby who at 5 days of age was found to have this very large abdominal mass. The mass was not biopsied, but presumed to be neuroblastoma, and he was classified as low risk and was observed. And at 2 years of age, I have imaging here, after serial monitoring with ultrasounds, we demonstrated that all that remained was a very small indistinct soft tissue mass measuring 1.6 by 0.6 centimeters. And I have other radiology markers to help us even find the mass. It's so small. He is now 4 years of age, a very happy, healthy young man doing really well. And so this is a successful observation-only patient. And when we look at our 8-month-old, this was the patient with widely metastatic stage M disease who had favorable biology, so was classified as intermediate risk. The patient underwent 8 cycles of moderate dose chemotherapy and imaging at 14 months of age here. This was after those 8 cycles of therapy really demonstrated complete resolution of metastatic disease on this MIBG scan, and this was confirmed by CT imaging. And all that remained on our CT was a very small soft tissue mass, less than a centimeter at the site of the primary tumor. And again, all of the metastatic sites, including disease we saw in the chest and in the bones, was all resolved. So a very good partial response. The patient is doing very well 3 years from completing therapy. So we can see that in a patient with mildly metastatic disease, but favorable biology. So what are the future directions for non-high risk neuroblastoma? Is there a role for expanding the group of patients with localized disease that can be observed? Or have we really reached the standard approach for this cohort? And if AMBL 1232 and the SIOPEN studies are positive for observation only, perhaps we have completed our work in that group. Similarly, for the MS patients, if results of the current studies are favorable, have we reached a standard approach for these patients? It seems in patients with localized or metastatic disease, but biologically unfavorable tumors, there is work still to be done. Is there a better way to classify these patients? Perhaps focusing more on biomarkers rather than just stage, and that would allow us to group patients and ask a therapy question. So can we determine the non-high risk bad actors? Again, are there new or better biomarkers that would help us to identify patients? And maybe we need to rethink our strategy of classification. Will a study be feasible? So how many patients with L2 and M stage disease are there, especially those with unfavorable biology and poor prognosis that would be worthy of a clinical trial? One of the challenges with finally classifying our patients into cohorts based on prognostic features is that the groups become quite small, and it does make asking a research question a bit challenging when you have small patient numbers. And similarly, when you're studying a group of patients with fairly good results at baseline, showing a difference with an intervention can be challenging, and you have to need large patient numbers. So it is something to consider as new studies are being developed. And what would be the new therapeutic approach? Would we continue with the standard chemotherapy, just alter the amount of therapy? Or should we really look at different agents and modifying therapy? Chemoimmunotherapy, backbone might be of interest. So immunotherapy is certainly shown to improve outcome in patients with high risk disease and relapsed disease. And is there a role in some of our less favorable non-high risk patients. So dinutuximab, our monoclonal antibody against GD2 with chemotherapy, for example. And is there a role for international collaboration for a phase 3 study? So as I mentioned, sometimes patient numbers can be small, and tremendous achievements have been made and knowledge shared with our international group. So maybe there's a good way to pool our resources and answer some of these questions. So I will leave you with questions, but I hope that this has given you a snapshot of the non-high risk neuroblastoma population and a little bit of the story of how we've developed our standard of care. And just wanted to acknowledge in particular patients and families who are really at the heart of all the progress that I've been able to discuss today. And a special thanks to the organizers of this symposium. It was really a privilege to have been included in the talks today. And I've had the great fortune to chair the COG AMBL 1232 study and have had a great deal of help and mentorship, and wanted to recognize a few individuals here. So with that, I really greatly thank you for including me, and happy to answer any questions.
Thank you so much, Dr. Amini. That's excellent. I would just encourage, if there is anybody who does have questions, to put them into the question and answer box, and we will get to those. We do have one question that's there now, and it's what, in your opinion, or what is your opinion on CBD, or the use of cannabinoids as a support treatment for neuroblastoma, and maybe in particular for intermediate or potentially low risk, and is there any consideration for studies in this area?
So I've had several patients who have had great success with symptom management with CBD. So I can say I'm definitely a proponent of that in certain circumstances. And I think things that we can think of to control symptoms outside of our normal pharmacology is really important. I think in general, the non-high risk patients, and this isn't true across the board, but the chemotherapy is fairly moderate. And so I think if the question is more for our symptom management, I've not needed to escalate to CBD or cannabis for my patients in that group, but certainly for the high risk patients where we think that the therapy can be more nausea inducing and certainly more problematic, it's something to consider. You know, one challenge too in the non-high risk group, and that this does bleed over into the high risk group, is that we're often treating really young patients. So one consideration that I've had in terms of personal experience with patients is making sure that we can find appropriate doses for our youngest patients, and that both the physicians, our pharmacists, and families feel comfortable with appropriate dosing. So I'm not aware right now, to be honest, of clinical trials in neuroblastoma, but I think, you know, a lot of these newer therapies are gaining ground, and clinical research would be really important to both prove efficacy and dosing for our young patients.
Thank you. What is, for the low and intermediate risk groups, what is the risk of relapse for this population?
So for the patients who have certainly localized disease and favorable biology, the risk can be as low as 5%. So they really have excellent outcomes, and the chance of their disease coming back is quite low. We certainly have a higher risk of relapse in our patients with unfavorable biology and those with metastatic disease. So it can, be closer to 20%, and in some groups even higher. I will say that many of those patients can still be salvaged, so that the overall survival, even with relapse, can still be quite good in a fair number of those patients, which is an important thing to consider.
And what is typically you'd mentioned a little bit about the treatment for that relapse disease. Mm-hmm. Can you just talk a little bit about, is there a sort of a rational pathway for how patients are typically treated if they relapse?
So I think it depends a little bit on what the patient received up front. So if we think about patients who have disease progression or disease relapse who were observed up front, and their tumor comes back as localized and could be easily resected. In some patients, would just do an upfront surgical resection, and that could be all that they need for some of our other patients who were treated with minimal therapy, for example, a patient who received just 2 cycles of chemotherapy, achieved an adequate response, but then the tumor did recur or grow back locally, it may be reasonable to consider just continuing with additional therapy. Perhaps 2 cycles just wasn't enough and they just need more additional intermediate risk therapy. And I think the situation is a bit different for patients who have multiply relapsed disease or patients who recur with metastatic disease, certainly, and the therapy needs to be augmented for those groups. Many patients are treated, I think a standard salvage regimen is using cyclophosphamide and topotecan, but some patients do actually require escalation to even higher risk therapy if they do have widely metastatic disease. And certainly if the biology of the tumor were to change, which typically it does not happen, but is something that we always, or I can say, I usually do look at and just make sure that we're dealing with the same biology of the tumor.
Thank you. We have another question here. So can a favorable biology tumor in low and intermediate risk groups malignate by biology change?
So getting to whether the biology would change in that tumor. So yeah, I think it is quite uncommon. For example, a patient who was initially MYC non-amplified to have a tumor that became MYC amplified. I think things have been reported, but that's quite unusual. So generally the biology does stay the same and we don't see changes. But again, I think it is important if a patient does have either a lack of response or disease progression that considering relooking at the tumor biology to be sure that it wasn't a sampling error in the beginning, but also making sure that there haven't been changes or additional studies that should be looked at in a patient that didn't respond as we would expect. I hope that gets to the question correctly.
Thank you. So I guess one thing that I mean, my experience is in the high risk world, but when I think about a parent who is told to watch and wait, that could be very challenging emotionally. And I'm just wondering if you could talk a little bit about that and maybe potentially what supports are given to that family who are in that scenario, and I guess even the monitoring that takes place and the way to put their minds at ease that observation is a great thing. But I can imagine that could cause some anxiety and that desire to want to do something. And when you don't do something, that's very different than in the world of cancer to everything that you know, right? And especially because the high risk is so predominant, even just going on a neuroblastoma Facebook group or learning things online, you'll see so many other people talking about treatment. And that's such a different thing in observing. So I'd love to hear about how you help families through that.
I think that's a great question. And it's really hard. And I find myself as I'm talking with new families, appreciating the challenge of saying, your child has cancer, but it's not that bad and they're going to do great and we're not going to do anything. We're not even going to, in some cases, do a biopsy to prove it's cancer. And it's a tough conversation, I think, because I can imagine putting myself or trying to put myself in those shoes and thinking, just take it out and be done with it. And how can you leave a cancer in? So I think, part of my job is to really explain, in part I take from some of the things I talked about today to just explain how this is a proven approach and very safe, and talk a little bit about the risks of surgery. And I don't use that to, worry parents, but just explain this is why we avoid some of these things, because there are complications with anesthesia and with surgery. And these patients really do very well, and we are going to watch carefully. And if there's any change, we will be ready to intervene immediately. And, I think the one thing that does help in many cases is that for these non-high risk patients, often these tumors are found incidentally, not always, but in some cases they are found incidentally, particularly the patients that are going to meet criteria for observation. So the kids look great, babies look great. The prenatal ultrasound patient that I mentioned, had we never had that scan, looking at this baby, you would never have known. So I think that does help a little bit that their kids don't look sick and we're not doing something. But it often takes a couple of conversations. And I've never had a family insist upon therapy. So I think there is enough information out there to help them to understand that this is the right approach. But I can imagine hearing your oncologist say this and just wondering, what are they talking about? I do try to guide them and show them some of the websites that focus more on the intermediate and low risk populations, because I agree, I think a lot that's out there that you might find just by Googling really focuses on high risk disease. And one of the first things I tell families in this situation is neuroblastoma is not the same. And if you Google neuroblastoma, more than likely you're going to be reading about high risk disease, and it's a very different beast. And that's not what we're talking about here. So I try to help with some websites and some patient groups that might give them some information that's a little bit more relevant to their patient, to their child.
Thank you. I guess one thing I'm curious about, you had mentioned, especially for those patients with persistent disease or who the possibility of the introduction of immunotherapy into the treatment for patients who might have a more inferior outcome. So I found that very interesting, and I think it's certainly the direction that is happening for high risk disease. I was just wondering if you could talk more about that. And I'm certain, my understanding would be that it would certainly be the attempts to address the long-term effects of chemotherapy and to try and remove those, because even at the moderate dosing, as you described, there's still the potential for long-term effects for these patient groups. And if potentially we're not seeing those with immunotherapy, then that introduction of that is really quite intriguing about and what it could do for patients and families.
Yeah, I think it would be a really interesting question, and certainly not for all patients. I think it would really apply just to those who still have an inferior outcome and in whom we would be considering an escalation of therapy, and whether that escalation should be a more intensive chemotherapy or thinking about a new modality. And I think the immunotherapy question really is a good one, because as you said, we hope that the late effects of immunotherapy and minimal, and it adds an agent that has a very different mechanism of action. So, sometimes with neuroblastoma, we've been fortunate to have successes by adding more and more therapy, but I think some of the successes more recently have also been by adding agents that work differently, such as immunotherapy, and that may be a reasonable approach. I think the trade-off is, certainly immunotherapy comes with more acute short-term side effects. It's a hospital admission, at least in our protocols at the moment, and here in the States. And so I think when we talk to families about coming for outpatient chemotherapy that's pretty moderate dose versus coming in for 5 days and having fever and the potential for cough and edema and all of those things, it's a careful balance. But I think the trade-off could be decreased side effects and an improved outcome has been shown with the high risk and relapse population. So it's something to consider. And I think it's something people may be thinking about as we're trying to find this group that needs augmented therapy.
Thank you. So I guess someone had just commented that to say that is hopeful because her son has many late effects from surgery and chemotherapy just from the tumor placement and surgery. So I think the late effects are something which parents and families really, and once you're through treatment, that is obviously becomes a huge concern. And so along those lines, what does aftercare and the long-term follow-up look like for the low and intermediate risk group?
So, my general practice has been for those patients who have had just observation or surgical resection. If the resection was not complicated, I usually follow them just in our oncology clinic for several years to be sure there's no sign of recurrence and just make sure that they're growing and thriving. And I don't always send those patients. We have a survivorship clinic, so I don't always send those patients to our survivorship clinic. However, even the intermediate risk patients who do receive chemotherapy, once I've transitioned them from our oncology clinic, which is usually about 5 years from the end of therapy, I tend to hang on to my patients for a while. But I do transition them, even if their risk of late effects with the chemotherapy they received is quite low. I think it is really important to have the group that focuses on survivorship, focuses on late effects. Our group does a lot of education about preventing cancers, and I think that's important in any child who's had a malignancy. So I think that group plays a role. They do follow patients annually, and prior to that, I usually see my patients every 6 months, but they'll do an annual visit, but a very comprehensive visit at that point in time. And for any patients that have needs perhaps outside of oncology, endocrinology, orthopedic surgery, if there are any issues or general surgery, related to therapy, we have those teams available as well. So I think we really treat any patient who's had an intervention as an important patient to be followed in our late effects clinic.
Great, thank you. Do you think there is anything that we can learn from neuroblastoma that spontaneously regresses that could help us understand more about the disease as a whole, and even particularly at high-risk disease?
Yeah, I think it really is an interesting thing to look at, and I think the mechanism of how that happens is not quite clearly or completely understood. And this is another thing that families often give me a little bit of a look when I say, well, there's a chance this is going to go away without any intervention. It's going to, just spontaneously disappear. And I think, the question as to whether it's something related to, the genetics of the cancer cells likely as part of it, or I think it's even been proposed, is it, they're an immune mechanism to the spontaneous regression. But if there were a way to better understand that and something to target, I think people are certainly looking at that. One thing that could help, and I think we hope help, is the tumor bank that we have. There's a very large neuroblastoma tumor bank, and certainly a lot of that has been focused on high risk disease, but even our younger patients who have low and intermediate risk disease are really encouraged to submit their tumor so that we can have perhaps even these serial biopsies to understand a low risk patient, perhaps that went for surgical resection. What does that tumor look like? A low risk patient that progresses, what does that tumor look like? Or in the case of an intermediate risk patient, do we see signs of differentiation and better understand that? So although I am going against what I said about tissue biopsy, we do try to avoid it, but if it is indicated for other reasons, then storing that tissue in a bank to understand some of these phenomenon, I think could be really meaningful.
Thank you. So Dr. Meany, thank you so much for your time today, and it's very, very insightful presentation. And thank you to everyone watching and for your questions. We really appreciated the discussion. So we've reached the end of our session, but up next after the break, we have pain and pain management and cell therapies in neuroblastoma, which is a panel session. So remember, if you miss a session, it will be available to watch shortly after the live session, and it will be on the on-demand page on the website. So Dr. Meany, thank you so much again.
Thank you, it was my pleasure.
All right, take care.